Thanks very much indeed, John and Nicholas, and for the committee for inviting me to talk. It's perhaps a little less sexy than all the talks we've had so far, but I would say this session is probably one of the most practical sessions that you really do need to get to grips with. And at a national level, I think that whether we like it or not, governments do speak to each other, and I can tell you that the British government is indeed not just through Brexit negotiations speaking to the German, the French and any other government that wishes to speak to them, but at the health authority level, they are learning from each other. And I think that's important. At the end of the day, we are one set up across Europe. Our patients are exactly the same patients. They have exactly the same needs. And it would be absurd to think that we are going to end up with a system that looks very different across European countries. We need to have a similar system, and so a meeting like today is the opportunity for us to transmit information and make interesting changes to our own country patterns to allow equitable access of treatment. And that is at the end of the road, the most important thing for patients, and certainly in the UK, the National Health Service believes that every patient should have equal access to treatment. So this process of centre selection is key. Now, I've put here the challenge of developing centres of excellence, but I've modified it slightly to cell and gene therapy. Of course, today's meeting is about CAR-T, but CAR-T, as Christian said earlier, is just another advanced therapeutic medicinal product. And we are facing a slew of products coming through that are going to challenge mainly hematologists and transplanters because we have the facilities, the technology, and previous experience in delivering these therapies. So I'm just going to expand that a little bit. So I think the fascinating thing for me is that, and this is a paper published in Science in 2013, so cancer immunotherapy, T cells on the attack, breakthrough of the year. Now, normally when you see a publication in Science in 2013, it would take 7 to 10 years before you would see that product in clinical practice. These products have subverted, in my view, the normality of pharmaceutical production in producing a drug. And these are drugs by European standards and American standards. So we've gone from phase 1, phase 2A. Remember, we have been talking about studies that have treated 76 and 111 patients. And these products are now licensed. So I think it has caught most of us on the hop. We are not necessarily ready for these products, but we need to introduce them at pace. So from 2013 to 2017, so here we have 4 papers, and I make the point, and I put on here 2 papers that are not CAR-T, of course they're not, but they are haemophilia. Now, these are ATMPs. The likelihood is that when you work in your institution, you may have a biological safety committee, as we do. I chair our biological safety committee. I have to review all products that are ATMPs coming through my institution, not just the CAR-T products, but all the products. And these products will likely, because we will have to represent our pharmacy colleagues, they will not have liquid nitrogen facilities. They may have quality management facilities. They will subcontract the work to the stem cell laboratory, mainly run by the hematologists and transplant physician groups. So I think it's for all of us to be aware that we have seen rapid progression from 2011, when the first patient was treated, 2013, the Science paper, to now full-blown licensed products, as we've just heard, in 2017 in the United States and in 2018 across Europe. So fantastic time, but we need to be aware that there's more than just CAR-T. And this is a very nice review by Mark Laudel in BJ Heme, looking at the different products. Now, this is what you and I have been doing for donkey's years. Treating patients with minimally manipulated stem cell transplants and DLI. But this is what's out there now. So you are going to get approached by colleagues in your trust to deliver not just the CAR-T. We've already heard about the ADA SCID, the thalassemia and sickle with Bluebird Bio, and then some of the gene-edited products that are coming through as well. I believe that Novartis have an early product, gene-editing product as well in sickle. And then tissue-engineered products that are going to demand your time and effort. And someone was talking about who's going to pay for all this. Do I have the bandwidth in my department? How am I going to manage? I'm struggling just trying to deliver the BMT work. And I think I saw on a tweet yesterday from Carl June, very good Twitter, it allows you to follow a meeting. I was in a meeting in London, so I wasn't actually able to be here, but I followed the meeting completely. But he showed something very similar to this, that actually if one just looks at the demand in oncology, we are on vertical takeoff mode. And that's assuming that's just cancer, but you've got a whole load of things here. And we have been involved at King's in neurological disorders, cell and gene therapy for monogenic genetic disorders, eye disorders, and tissue repair. So it is not just CAR-T. So I just want people to focus on that. So in the UK, as part of the decision-making process, the government decided that ATMPs were important and that we needed to develop a process and a program. We also needed to ensure that this was not just going to be, as you heard earlier, perhaps one or two centres that have been doing basic research in this area, University College London and King's for sure, and Imperial in London, other centres slowly coming on board. But if we're going to develop a national program, then we need to have a way of ensuring that we have regional distribution of the delivery of this service. So the government put a bid process in 2017 with decisions in 2017 to increase patient access to ATMPs, establish best practice for safe and effective delivery to patients, good manufacturing, we've heard about that, that's relevant to us, we understand that as being a JC Accredited service, supply chain issues and traceability and tracking, and data capture. So you can see the themes that we've heard already. And this is a funded network that will report through the Cell and Gene Therapy Catapult. I think that's an opportunity for us to look at that and say, is that a model that we can introduce in other countries? And I know that the German groups have been looking at similar models and Spanish groups as well. So we're all doing the same thing, but we're not necessarily learning from each other as we do it. So when this bid process happened, centres put in bids, and these were the selected centres. Some colleagues of mine would say, excuse me, where's London on here? But London has already got a significant network in place. So I think it was to ensure that there was a fair distribution so that around the country we had good other networks in the northern part of the country, here up around Newcastle, Glasgow, Edinburgh, then Manchester and Leeds, and then Birmingham, Cardiff and Nottingham. And indeed, the London Advanced Therapies Group already has a network which is funded. So you can see here between UCL, KCL and Imperial. Now this is not just for CAR-T, this is for monogenic gene therapy disorders, this is for treatment of cystic fibrosis gene therapy, as well as other therapies, because the logistics and the issues that you will have are going to be very similar. So you do need to be ready for that process. So as part of that, and we heard earlier, these are drugs. Your pharmacist is nominally in charge, nominally. Now, I have spoken to a number of colleagues around Europe, and I'm aware that in some parts of Europe, the pharmacist says to the transplant physician, I'm in charge of this, you do what I tell you to do. Whereas I think what we need to do is work collaboratively with our pharmacy colleagues. So this is a document published in February 2017, and it continues to be updated. So the role of the pharmacy in the successful delivery of ATMPs, because they've got work to do, so we need to partner with them. So this is a useful baseline document for centres to work with, to prepare the ground for delivery of these ATMPs. And As a separate addendum to that, the publication here in December 2017 from the ATMP Working Party, again bringing chief pharmacists around the country so that every hospital can't say, I've never heard of this. It's about making sure that the groundwork has been done and the chief pharmacist is intimately involved in the delivery and management and process for your group of patients. And so it focuses on procurement of starting materials, receipt of drug product, pre-infusion patient treatment, issues of drug product care and post-infusion care. All the things that we recognize but don't assume that they know anything about it. Indeed, I asked that question of a pharmacist in 2017. I said, what does ATMP stand for? And they just looked at me as if I'd come from the planet Zanussi. They had no idea what I was talking about. So it's important that you bring them in. And if I can call it, we were planning for it because in my role at the time as and John Snowden's now taken over, as the chair of the clinical reference group, we were horizon scanning new products coming through. In my role with NHS England, we've had numerous meetings with the pharma industry and others about products that are coming through, and therefore we set up what was an interim specification. Not just my thoughts, but the thoughts of many others about what is required to be an ATMP CAR-T delivery centre. I spoke to American colleagues about size of centre, what sort of centre, and we came up with this. So not all ATMPs are difficult to deliver, and not all ATMPs are quite as complicated as CAR-T with the toxicity, but some are, and there can be fatal side effects. We thought that JC accreditation, both as a collection and clinical centre, and good service level agreements within the network were important. Significant run rate. Steve Grupp said to me, a centre should be doing probably 40 to 50 allografts per annum. 20 paediatrics, if you're doing paediatrics. Now that immediately meant that, and John and I both know this, that in the United Kingdom that quickly selects out most of the centres. Because they're not doing that run rate of transplantation. They need to have good experience in complex allogeneic transplantation and not just autologous. That's a UK view and not necessarily the view of every country, but it's something you should seriously consider. Ability to participate in long-term follow-up and registries, written agreements, the importance of intensive care and access to dialysis, and we have stipulated quite clearly that centres cannot have an intensive care where an ambulance is required to transport the patient to intensive care. Intensive care has to be co-located on-site with immediate access, both for adults and children. Multidisciplinary working, that this requires significant multidisciplinary working, neurological, renal, hepatology expertise, not necessarily co-located, but in place. Good hematological expertise. So I think there are issues with CAR-T that an oncologist, if they were delivering this, may or may not necessarily understand. We understand neutropenia, we understand infection far better than they do. Experience in leukapheresis, there are many intricacies of this delivery for leukapheresis, and pharmacy and cell therapy lab, and liquid nitrogen facilities. It's a point I'll bring up later. In some centres that use passive freezing and mechanical freezers, they may or may not necessarily have liquid nitrogen available, so it does need to be available. And so we set up this process, what we think of as part of the initial phase, what is mandatory, what should be on site, what could be just referral, etc., to create the safety net as we introduce this product into clinical practice. It doesn't mean this is how it will stay, but this will be the base of our decision making when we come to the decision making about the centres. So we had two products in front of us, one from Novartis and the other one from Kite Gilead, and we felt that we could not have a single specification. So this is the National Health Service have specifications for this sort of treatment, and we stipulate the requirements for the process of delivering this therapy. So we ended up with a specification for the Kite-Gilead product and a specification for the Novartis product as separate specifications. So we developed that, but we developed it in collaboration with the companies who had to provide us with information that was not, that was business sensitive and that was not necessarily in publication, so that we were able to understand the warts and all. I always say that's about negative publications that don't get published. So we ensured that we received all appropriate publication data so that we could make a valid decision about specifications and what was required, the time that patients would need to be on intensive care, the commitment in a hospital of how many beds you're going to have to put aside to receive a patient. You know, it's probably 1 or 2 bed days per annum, or 1 or 2 beds per annum for a large centre delivering this. Do you have the capacity? You have to have the capacity. So we co-developed it with the providers, and then we brought in a load of clinicians, experts. So we brought intensive care experts in, we brought neurological experts in nationally to come together, and John was within this group to formulate this process. And then this document went out to public consultation. That may be a very British thing, but that's what we do to ensure that people could input their views as to whether this was appropriate or not. So we felt that these slides are going to be available anyway, but we felt that to ensure that no one could point a finger, and perhaps that was me worrying that people might point a finger at me saying, you particularly chose King's as one of the centres, and that's unfair. So the decision-making was not made by people like me, nor indeed John. We were kept out of the equation, and we asked JC to provide the help and support to come to a decision about whether a centre would be appropriate for delivery of CAR-T. So applications were put in from centres, and I think we had 17 applications, and JC and the NHS England basically picked 9 transplant centres for JC inspection, and they were based on a geographical distribution and readiness, i.e. that they may have already had some experience in CAR-T production, so that patients would not have to travel long distances, hopefully, once the network was in place. So we had dual manufacturer accreditation and JC accreditation running in parallel to come out with, in the end, a finalized contract. And so for JC, that was a fantastic response, a difficult ask, because we were asking them to do this at pace. This wasn't, oh, can you do this next year? The NHS England request was centre's expression of interest from NHS England, JC selects the centre within a month, and then the inspections had to be done over the summer, which is never a good time, but JC stepped up to the mark and did the deed so that we were able to define the accredited centres in readiness for, hopefully, delivery to patients once NICE and other groups had come to decisions. So you had this parallel process running up here. And interestingly, JC and the companies don't necessarily always agree on the readiness. So the companies have one set of requirements. They're very similar, but sometimes a department may have passed their JC tick, but not passed their onboarding with the company. So you need to be aware that there are differences. I always say it's the same thing. If I have a JC set of inspectors 1 year, they say one thing. If I get the MHRA in, they say another thing. And it's amazing how they don't agree with each other. So it's not unexpected that the two processes would find slightly different issues. So from the inspection format for JC, and these are slides that McGrath has kindly provided to me, the 2 to 3 inspectors, a clinician, adult or pediatric, and a quality manager, initially in the vast majority of centres in the UK just going in to do the immune effector standards, the 42 standards which I'll touch on. At King's, unfortunately for me, we were having our JC accreditation visit at the same time, so it created some problems. But what they were assessing, training, education, quality management, traceability, interactions with key supporting services. These are important because we had highlighted this as being very important in our standards, that we have to have co-located intensive care and preferentially neurology. That has created a real issue for some centres in the UK who don't necessarily have a neurosciences facility on site. They may be distant. And management of expected SAEs. And then obviously the custody requirements for all of these products are important for both of them. So good interaction with the stem cell lab, etc. So these were the 42 standards that centres were being assessed against. And I think it's important that JC were being used as the good manager in this process, a third-party individual group who could, without pressure, make a decision as to whether a centre technically had the capacity to deliver this product. They were not saying, we are designating the centre. They were acting as the inspectorate to say whether the centre would be able to deliver the product, and then NHS England would make the final decision on that final list. So know your role. So JC played a fantastic role in this decision-making process in the UK. And of course the question is this a key balancing role that could be used or rolled out in other countries across Europe? I don't know what the answer to that is. Again, Owen has provided me with this slide. So there are pros here. JC recognises the standards, established JC as the exemplar organisation for delivery of all IECs. The cons, from our point of view, were that the timelines were quite tight. How many of these inspections are we going to ask JC to do? Can JC cope with the number of inspections? The answer is, I'm not sure. How many of the inspectors actually have CAR-T? Well, over the next year or so, I think we will have a lot of inspectors who will have that knowledge and be able to go into centres and support that process. So through that process of both collaborative working with the industry partners, we are twined at the hip. We are inseparable twins now, I believe. We do have to work collaboratively with them. So our view is that we have the patient in the middle, but the industry partner, JC, and in our healthcare system, or your healthcare system, the public provider of healthcare who pays the budget. And so the decision was made that on the centres that applied, we would try and provide 2 clear children's facilities to treat children with ALL, with the Kymriah product, aged up to 25, as per the license. The numbers, we did a piece of work on the likely numbers in the United Kingdom of patients with ALL and with non-Hodgkin's lymphoma satisfying the appropriate criteria. And we came up with numbers of 20 to 30 ALLs and 200 non-Hodgkin's lymphoma. I saw some data in the Italian press, which someone sent me recently, that they're suggesting there might be 800 non-Hodgkin's lymphoma in Italy, and I don't know whether the incidence is different, it might be, but you can see that there are significant variations in what the target number of patients we're going to have, because that has implications on what is the best size of a CAR-T centre. We were talking over coffee, there are some centres in the United States, NMDP harvest centres, they're saying, thank you, we're not doing NMDP harvests anymore because we're focused on CAR-T. So do you have capacity? How many of these products can you deliver a year? Could you deliver 2 a week plus other trial work? Now that is a big ask, and it's something that you have to look deep into your own heart to be able to say, we can or we cannot do that, because I think if we say we can and we mess it up, then this could be quite a dangerous scenario. So the centres concerned here have promised or given significant guidance, and that comes from the chief executive of the organization, that they will be able to cope with appropriate numbers of patients, they will always have access to intensive care, and they will always provide neurological input, etc., with service level agreements written in blood. So these are serious agreements that are being put into place. So the centres that are being defined in London, obviously Great Ormond Street, as I said, for children, UCLH and King's for adults, Queen Elizabeth Hospital in Birmingham for adults, Manchester Conurbation, both children and adults, and then Newcastle. Now, Cardiff here is ready to open, and of course Glasgow is opening as well. But other devolved nations, for example, Northern Ireland will either likely, depends on what happens on March 29th, either send patients, as they currently do, to Dublin, or they'll send patients to the UK. So we shall see what happens. But you can see from this map, there are big holes in the UK. So there are bits of the UK that don't seem to have a centre at this very moment in time. What we wish to do was, this was a staged rollout. So this was stage 1. Stage 2 is in process at the moment. So the centres have applied. There are 15 centres have applied, and you can work out for yourself where there's no blob. And it's likely that where there is currently no blob, there may be a blob. So I don't know how many centres will fall out of this, but you could imagine there might be some holes here, and perhaps one up there, and others. But either way, it will not be our decision. It will be a joint JC NHS England decision to ensure that patients don't have to travel more than about 50 to 70 miles to receive their appropriate therapy. And so one of the worries, and I don't know what's happening in the rest of Europe, well, I do know what's happening in the rest of Europe, but one of the worries about a system where equity of access is important, they wish to be assured that a patient who is sitting in Plymouth, or a patient who is sitting in Sheffield, John's hometown and my near hometown, has the same access to therapy as a patient sitting at King's or at UCLH in London, where there's a great deal of experience already. And so to ensure that, and also initially when both of these products were released, there were issues of capacity, not only from the centres, but from the companies. We've heard already now, I think a lot of that is being overcome by opening up of additional capacity production. And so I think the capacity is less of an issue. But I think as more and more countries come on board, demand will go up, and there may be a capacity issue. We are in competition for slots. Christian made that point earlier, that there are competition for slots. So as an introduction to the process, the government decided that we would introduce panels, CAR-T clinical panels, to ensure that the patients being treated were absolutely eligible as per the indications, and to manage supply and demand. This was something that we felt that would be useful to start with. There is a panel for ALL, and there is a panel for non-Hodgkin's lymphoma. And John indeed is one of the chairs of one of the panels. I won't say which one, just in case people try and tell him, buy him a drink and say, please let my patient go through. But essentially, it's there to start the process. It's not clear whether these panels will go on for very long. Once we feel that we have understood the process and that the referral systems are in place, these panels may well be dissolved. But either way, these are quite a commitment for the individuals concerned. They're clinically led, clinical chair and 3 clinical experts from non-CAR-T centres. So these are lymphoma experts or AL experts that have no conflict of interest in this process. Pharmacy, the Cancer Drugs Fund, CAR-T centres are present, and 2 public representatives. Weekly meetings, and they assure that the patients are eligible, and as the capacity constraints settle, we may be able to reduce that process. So what are the key lessons that we feel that we have learnt from this introduction and decision-making around the choice of centres and delivery? Well, we have new standards that we've had to work with, completely new logistics, clear, as I said earlier, that we are working in partnership with our company providers. It's brought us, we were just talking earlier, brought us closer to NICE, brought us closer to EMA, brought us closer to the other regulatory authorities as we're all having to interact. From our point of view, as much as the data's out there, these are licensed products, there is still quite a lot to do from the point of view of evaluative commissioning, managing the capacity and demand, and also learning about the toxicity, shared learning, and ensuring that this is transmitted around all our colleagues in the UK, and I'm sure across Europe. So there are going to be quite a few fora. Now, I just asked Novartis and Kite Gilead to give us some views about what they felt about this whole process with the UK. And I think the lessons learned are that if you're going to bring these products in, getting in early, horizon scanning, meetings with NICE, DH and NHS. I was in some of these, well, I was in both of these meetings very early on. NICE assessment, and then introduction, because I sit both there and there, bringing the commissioning together with the early stages of the process. So there were no scares here. We knew what was coming. What we didn't know is when EMA would license it, but it happened. And then from the point of view of Centr's concern, issues here about the time taken to get contracts reviewed, there are problems here that little things will stop your department from delivering therapy, things that have got nothing to do with you or I, but your chief executive not signing a piece of paper or your pharmacy not agreeing something. So you've got to get all of those things into place. So, as I said, this perhaps is important, full candidness, being very open, and having someone who is motivated in your facility to get this to happen. Not in a research way, but in a bog standard routine delivery process. And that's sometimes, there's a disconnect between the academic side, as I call it, the boutique, or in French terms, the Carrefour supermarket, i.e. big and have to deliver lots of things. So you need to be aware of that. And to be fair, Kite Gilead, I asked them again, and I think the understanding the local landscape as they come in and do the onboarding processes, strong partnership, we've already heard that. There is a lot of training. You know, we have probably trained 300 people. That's a lot of people to train. And if you're having to train 300 people for one product, the same 300 for another product, and then perhaps a third product coming soon, and then all the cell and gene therapy products that we're using, this is a Goliath task. And to maintain that knowledge base, to ensure that this patient safety is core, it's going to be a lot of work for all of us. And then there are some issues. There's a very specific issue in the UK. We believe that all products should be overwrapped. Christian showed a cracked product there. That was an ordinary product. Because of something that happened a long time ago, the MHRA stipulated in the UK that we have to overwrap all product. The companies don't allow us to overwrap the product because the product is a licensed product, and the commercial decision is that this product arrives in its steel wrapper and you cannot touch it. So it creates some tensions in the discussions. And I think we all need to be aware of that. So, and also, they each have slightly different requirements for the temperature storage. You need to be aware of that. So it's not the same. So I think from that point of view, learning from all of that, speaking to American colleagues and others, this is what we call our King's CAR T-cell therapy team. Someone with a team of 6 consultants who look after these patients. Most of them are transplanters, but not all. Everyone's trained, JC program. We have a specific ward where we deliver this therapy with trained nursing staff. Pharmacy are intimately involved in this, stem cell lab, of course. We have appointed ICU-linked consultants who are paid to do this. We have neurologists who are paid to do this. We have cardiology and renal input. And very important research nurse coordinators and clinical nurse specialists specifically for this. And from our point of view, we have a mind and body program, we have a psychologist and a psychiatrist associated with the program to ensure that the patient is core to all of this and gets the therapy safely and hopefully effectively. And sorry if I'm not sure I've gone over time, perhaps I have or I haven't. Thank you very much. And
we'll open the floor to questions and discussion. You might want to stay up there and field some questions. Have we got any? Shall I get the ball rolling? What did people think about the JC standards in relation to being one of the determining criteria which we've used in the NHS England approach? I mean, it's obviously a criterion that's open to other health services around Europe. Anybody got any feelings about that, or any other questions? Any questions about should it be allogeneic centres versus autologous? That's controversial, isn't it? Should autologous only centres be part of this CAR T-cell process? Tony, what about those sort of that issue?
Well, I suppose it was quite interesting. Alvaro showed the sort of, and I think Christian as well, that there are centres across Europe that are delivering this. They're not JC accredited, they're oncology centres, and this creates a tension. Look, let's be open about it. You can speak to the companies and they will say, the KOL from country X rings to say, my centre should be because I'm the world expert in disease X. Yeah, we all know that one. Because we all know that one. The answer to that should be very nice. However, tell me what your knowledge of delivery of these products is, and indeed, are you going to do the work, or are you going to ask your great colleague Herman, who's the transplant physician, or Alvaro to do the work for you? Because if that's the way we're going, then we are going to be overwhelmed with work. And therefore, having the JC allogeneic program in place, saying that, because, I don't think any of us disagree that an allogeneic program is slightly more complex than an autologous program. An auto is done in my sleep. I have to be awake to do an allogeneic transplant. And if you're doing mismatched unrelated, you're doing haploidentical transplant. What is a haplo? It's CRS. It's the same thing, isn't it? You get a CRS associated with a haplo. We have to switch it off in one way or another. It's got toxicity. A cord transplant is complex. Patients are neutropenic for a long time. So this is a very different beast to an autologous transplant. And if you look at all the data, I don't know, I sadly wasn't at the meeting the last couple of days, but all the data shows that many of these patients have protracted cytopenia. Not just a week of it, as per an auto, but 1, 2, 3 months of protracted neutropenia. A proportion of these patients are going to require an allogeneic transplant, I think. Some of the data supports that, some does not. But either way, the sort of issues that we face, neurological problems that we might see, are the sort of things that we've sort of got a little used to in allogeneic transplant that we have not in autologous transplant. So to start with, until the wizards come up with fancy new CAR Ts that we can reduce the cerebral toxicity with, or we can reduce the CRS and remain effective, then I think that it should remain in allogeneic centres. In the UK, that's not been an issue because we knew that we were not going to, we have 30 JC accredited allogeneic centres, but we were not going to, well, I was certainly not going to allow more than a handful to start with to start the process. In a year's time, we may have 30 centres, and indeed we may also start having autologous centres. But to commence the process, I think the right thing is to keep it to the allogeneic centres.
Okay, Nicholas has got a question.
Maybe first go on.
Yeah.
Tony, I wanted to ask you, do you think that some harmonisation between the clinical trials directive under which academic or commercial CAR trials are undertaken, which doesn't require JC accreditation or those safety processes that you mentioned, do you think that there should be some two-way talk between those? Because I think that at the moment it seems that commercial product availability is really going to be restricted, I think quite rightly, into JC accredited, IEC sort of ticked centres. But actually you could be running any trial in any disease using the European Clinical Trials Directive with no safety at all.
Well, I think that's where, so it's interesting. It's an interesting point, and I can see the validity of that argument. However, it goes back to what I said earlier. In Britain we have two supermarkets. One is a very posh one called Waitrose, and the other one is Tesco or Aldi or Lidl, as Germans will know. So these are the discounters. They do volume, but you don't get much quality. Whereas Waitrose, you get quality. When you're running a clinical trial, you have enormous quality. You have a handful of patients, you have a massive team of individuals who are scrutinizing absolutely everything. Once you move to commercial product in volume, what you find is you are stretched. The resource is not necessarily there. And I think many departments and many institutions may struggle to persuade the people in charge to give them the appropriate staff to do the work safely. So one of the positive things, not only from the company point of view, whose onboarding process is quite strict, but also from JC, JC give us the de facto platform to be able to say, these are the minimum quality requirements. And as long as we have that, then once we go to volume work, what is volume in CAR-T? I can tell you, Steve Grupp says we're 75 per annum, we're maxed out. Yeah, we are busy doing 1 and a bit a week. In children, it's hard work as well. So if we are doing that sort of numbers, we will need massive resource. And I think the control has to come from somewhere. And I think that's why at least having that JC standard as well as the company standard helps us bring that control. I wish if we had all the resource we have for a trial, yeah, you get a trial in, you get stupid amounts of money for the companies to do the trials, and you can appoint a load of people, and isn't it all nice?
Okay, Sergio, then Nicholas. Short answers, Tony.
My question was with that. In your, it's like very much your systematics, no? But you have not talked on resources that is given by who will pay that. In other words, now we need to pay 300,000 euros to the companies, but you say, okay, we are receiving this in BMT units that are very busy, and what is the extra needs that this need to be? We need to create CAR-T units inside a BMT unit. There are many new quality management requirements, etc. So who?
So I think we're going to hear something about tariffs. So we're doing that piece of work at the moment. I have what I've said to NHS England, the payors, the people who are going to pay us, the 10 phases of treatment, and I have itemized, because there are massive dropouts. Some of these patients never get the CAR-T, so we never get the reimbursement. So we have to have a structured process that pays us at each step of the process. Now, for me, I put a business case together within my own institution, and I got 3 additional consultants, quality managers, nurses. So I was lucky. I was persuasive, and the trust supported me with £2 million on the basis of the projected income streams that would come in. We are having that discussion with NHS England at the moment. The new tariff, there is a temporary tariff until the end of March. That's not because of Brexit, but just the end of March. And then there will be a new tariff from April, which we have done bottom-up costing ourselves at King's, and Great Ormond Street have provided the government with bottom-up costing. I have a number in my head. I'm happy to discuss that personally or privately with people. I'm not going to say it out here because this is being filmed and I'll get into trouble. But I think it's absolutely right. We cannot do this work without the appropriate funding. It's just not going to happen. And we shouldn't. There is one institution in King's where the chief executive, in the UK, the chief executive is refusing to sign off because she says that the funding stream is not in place to deliver this product.
Herman and then Nicholas. Yeah.
I think we should always remind ourselves that CAR T-cell therapy is not standard of treatment in most of the hematologic malignancies yet. And I think a very important point is that we also have to learn. We have to learn why is a patient responding, is not responding, why is a patient developing toxicity. And I think we also should force all the centers that are using commercial products to do some accompanying research, to look for persistence. We had this discussion yesterday, to look for causes of toxicity. And therefore, I think this should be also an issue in deciding which centers are going to perform CAR T-cell therapy.
Herman, I would absolutely concur with that view. And I think if you speak to American colleagues, what they will tell you, you say, oh, tell me about this after the trial. We don't get funded for that. They're just delivering the product now and getting the reimbursement. So we have an opportunity to maintain that academic delivery in parallel with the commercial product, I hope. And Novartis and Kite Gilead and Celgene in the future, perhaps, that's what institutions need, that support.
Thanks, Tony, for giving us this presentation and the British way to go straight forward. So I was still wondering why, so the applicants were about 18 to 20, but at the end the NHS approved only 9. So when you said this was not your decision, neither JC, so what was really the decision by NHS to select the centres?
So I was not on the JC committee that made that decision. I think the JC, I discussed it with Owen to how was the scoring done. So I think there were some requirements about do you have any CAR T experience? And to start with, when this process started, there were literally only 3/4 centres that actually had CAR T experience. So that was already a problem. And then about the other facilities. So they gave a score and a rank, and then NHS England, on the basis of projected opening of trials, and there were some trials opening, that they would stretch it a little bit further. These centres were all accredited by JC as allograft programs with an interest, and we needed to have equitable distances. When the process started, and John knows this, King's was the only site in the UK treating non-Hodgkin's lymphoma. So patients were having to travel from Newcastle, from Bristol, from other centres around the country to King's. That is hard work. These patients, we believe, have to be within our domain for 30 days. We have to provide them accommodation, and we have to have a carer with them. So if we discharge them out and we manage them in ambulatory, there has to be a carer with them 24/7. So
I'm just wondering, because you have these blanket leaves on your map. On the other hand, you have Manchester, you have two centres which are just across the street, as far as I know.
that's a very, I wish I knew the answer to that. I won't give you an answer. I do know the answer to that, but politics is politics.
Okay. Thanks very much. That's okay.
Thank you.